28 or 30 patients a day who I'm seeing 10 minutes each slot back to back. I must admit, towards the end of the day, I am mentally exhausted. You mix that with a lack of time and a one-size-fits-all approach, and that's when you end up with a lot of healthcare professionals just, oh, here's a medication, try this. In most of the NICE guidance, all it says is encourage weight loss, encourage increased activity.
Welcome to the Visionary podcast, where we discuss science, medicine, physical health, and mental well-being. Dr. Nicole Hinds, before we start diving into all things sports and nutrition, you're a GP at Tunbridge Medical Group. GPs are usually generalists. Mm-hmm. Please take us to the moment when you realized you wanted to combine general practice with sports and exercise medicine. Was it like a light bulb kind of thing or a slow burn?
I would say it was probably more of a slow burn in answer to that question. I've always been very interested in sport. I've always been a sporty person. Done sports since a very young age. Come from a sporty family as well. But I never realised that I could incorporate sport so much into my medical career. When I started medical school, I naturally just really gravitated towards the musculoskeletal system. I really enjoyed the anatomy, the examination to do with it. At first, I thought I wanted to be an orthopedic surgeon. So a surgeon, a bone surgeon and a joint surgeon. But then I realised very quickly I didn't actually like surgery. So I was like, that was not going to be the route for me.
Too much blood.
No, it wasn't the blood so much. It was just, I think it was how long the training was to become a surgeon, and you have to rotate through all the other surgical specialties. And the surgery itself just wasn't for me. So I went into general practice and slowly started to realise that actually sports and exercise medicine could be incorporated into that. At medical school, there was a Sports and Exercise Medicine Society. Sports and Exercise Medicine is a very new specialty. It only became sort of an NHS specialty. I think it was 2006. I think it was when the UK put in their London 2012 Olympics application, and it started to develop from there. So it was only through medical school did I realise that you could actually incorporate this more. I started then doing more experience with sports teams, as well as gaining more experience in musculoskeletal medicine as well. And then I've just gradually built that side of my career alongside general practice, and now I'm incorporating it into general practice as well.
The concept of sports and exercise medicine can sound a little bit grand to the everyday person. Please break it down for us in simple terms.
So the Faculty of Sports and Exercise Medicine, or it's soon to be a college actually, breaks it down into three main strands. So the first strand is musculoskeletal medicine. So when you think about your injuries, your sporting injuries, or even injuries in just day-to-day life, back pain, knee sprains, ankle sprains, tendon problems, all of these come into sort of injuries. And so one part of sports and exercise medicine is helping to assess and treat musculoskeletal problems. A second strand that's defined within the specialty is that of team care and elite sport. So this is your kind of sports team doctor. So if you think about, for example, in football, I don't know which team you support, but take Manchester United, for example, they'll have a team doctor, and obviously they will be a sports and exercise medicine specialist. But all sports will have some form of doctor or sports and exercise medicine specialist within the sport. And the third, and probably one of the most important, I think, strands of sports and exercise medicine is actually the exercise medicine and using exercise medicine as a health tool. And there's a real kind of public health aspect to this. The UK, it's quite common knowledge now, we have a bit of an obesity problem with inactivity, and lots of medical problems that then derive from this, diabetes and high blood pressure, heart attacks and strokes and this sort of thing. And a massive part of sports and exercise medicine will be addressing this and using exercise medicine principles to really help prevent and treat what is a bit of a kind of obesity crisis and all of these other issues that sort of go with that. So that's the third strand. And I think that's probably the most important, particularly when it comes to how this specialty is going to help the NHS.
Absolutely. So you're telling me that exercise can be a medicine. Now, people might think that exercise as medicine is something for the elite athletes or professional athletes. Please share with us 3 examples of how movement or physical activity can impact diseases, conditions that people struggle with on a daily basis. We want 3.
3. That's going to be
or
really
4
hard.
or 5.
That's going to be hard to choose just 3 because the benefits of exercise medicine is huge. I mean, there is a syndrome which has the name metabolic syndrome. Now, metabolic syndrome is a group of conditions that all contribute towards the increased risk of heart attacks and strokes. So this could be being obese or overweight. It could be having an increased waist circumference and having a lot of abdominal fat. It could be having high blood pressure, having high cholesterol, type 2 diabetes. So metabolic syndrome is all of these conditions kind of grouped together to give it one term that exercise medicine can really help with. It can help to lower blood pressure. It can help to obviously reduce weight because you're increasing your calorie expenditure through being active. And then this has a knock-on effect with your cholesterol levels and reducing your risk of type 2 diabetes as well as heart attacks and strokes. So,
hi, I'm Hala, your host today. If you're enjoying what you see, please hit that lovely subscribe button. It would mean a lot to me and my team. Or maybe it's more now. We're still learning. We're still finding our feet. But with your support, we can build this channel. Let's take this journey together, one step at a time. Thank you so much for being part of it. It is hard to imagine for the everyday person that exercise can manage, treat, cure, because when we say medicine, it's cure, heal, treat, all these conditions. I mean, in 20 seconds, you have listed a lot of them, and I can list some of my friends who have these conditions, but they don't exercise at all. They are being given medication, which is, I mean, I'm not a doctor, so I don't know, but I want to drill down on the mechanism of this. You mentioned the metabolic syndrome that might lead to all these conditions. Okay, we know the general idea that if I work out, let's say daily, I will lose weight. Maybe calories in, calories out kind of thing. My breathing will be easier, heart rate quicker, so hopefully any issues will be detected quickly, these kind of things. But more than that, the general public, they don't know the full impact. Walk us through this mechanism. Is it like a direct impact of working out, hopefully regularly, obviously, and sustainably, with the assumption that diet is half decent, and maybe there are no genetic conditions that might be a significant impact on these? Like we will try to isolate the factor of exercise. Is it a direct impact that's like worth the investment of time and effort, because it's not that easy? Like, walk us through this, please.
So yes, there is evidence to suggest that actually pure exercise and activity alone can reduce the risk of all of these conditions. So there is evidence that actually you can be overweight and still be physically active, and it will still reduce your risk of high blood pressure, heart attack, stroke, that sort of thing. So physical activity on its own has a primary direct impact on all of these conditions in that metabolic syndrome that I mentioned. Added on top of that, if you are more active, obviously, like you mentioned, you are burning more calories, you are taking up more energy, which means that you are more likely to lose weight. And if you are of a healthy weight, again, that also reduces your risk of heart attacks, diabetes, having a stroke, having high blood pressure.
I imagine you as a GP see people across all fitness levels. How would you tailor exercise and medicine for those with chronic diseases?
It completely depends. There might be a lot of that with some of the questions that you asked, but the best way is to there are general principles that I can use to
protocols kind of thing.
To provide, for example, an exercise prescription. But these principles will be tailored completely depending on the patient that's sat in front of me. And I think there's a really big, I'm going to speak quite generally now, not just from an exercise medicine point of view, there's a really big move towards personalised care for patients. So previously, there's been just general principles, general rules, general treatment guidelines, which you would just give every patient, no matter, what their age, what their lifestyle is like. You would just say, you need this medication, you have this condition, you need this medication, here you go. Follow up in 3 months' time.
I love the idea of personalized.
There's a really big shift now
this
towards
was in a 10 minutes kind of appointment. How can we do that? Of course, it has to be personalized, but how can we do that?
That's a really good question. We try our best, but it's really hard.
Yeah, I was just telling Roy one of my stories about my conditions. I struggled. I still struggle with sleep issues, and I'm almost always sleep deprived. So when I went to see my GP, not my GP, she a GP, I've never seen her before, and I sat in front of her. Once my bum hit the chair, I started crying, and I was crying for 10 minutes, right? And she said, "So sorry you're struggling with this antihistamine." She never asked me about my diet. I'm not complaining or anything. I had amazing experiences with GPs, really, but she never asked me about what if I usually have huge meal before bedtime and I can't sleep. Like, what if I'm super sedentary and I never work out and that causes me not to burn enough energy so I can't sleep? What if, and one of my friends, when I told her what happened, she said to me, "So you're crying for 10 minutes and the GP never questioned whether you're mentally struggling or not?" So, no, she didn't.
I'm so sorry.
you know what I mean?
Yeah.
So definitely we need personalization but it feels right now, despite the fact that I had amazing carers on the NHS, whether it's primary care or the second line with consultants, amazing people, but I still feel that there is always a one set fits all protocols. What do you think of that?
I'm so sorry that you had that experience. And you're right. It's very difficult in the current NHS system. I think it's not, it's not news that the NHS is struggling and underfunded, and there's a staffing issue, particularly, in all areas, I think, but especially amongst GPs, at the moment where I work, there's, I have 10-minute appointments and they're all back to back, and I'll have 14 or 15 in the morning, 14 in the afternoon. So that's 30 patients, 28 to 30 patients a day who I'm seeing 10 minutes each slot back to back.
Yes.
I must admit, towards the end of the day, I am mentally exhausted. And obviously every GP is different, but from a personal perspective, it does get to a point at the end of the day where there's maybe not enough energy in my brain to really pick apart.
I appreciate that. Yeah, absolutely.
The underlying factors. I think the key is to pick up on what we call social cues. So of course, if I've got a patient sat in front of me and their main presenting problem is sleep, but if they start crying in front of me, I might have to make a mental shift in my head and say, actually, this consultation might not be about sleep anymore. I'm going to shift this and start asking them about their mental health. And I think it's trying to keep that open mind that the consultation might shift.
She didn't have the time, bless her.
But this is the problem. You might have been, and I'm, and it's not an excuse, and everyone does deserve the same level of care and to be treated the same. But if you're the 28th patient that day, and particularly if every patient's gone in and done the same thing,
I know. Yeah, I appreciate
it's
you go there because
humanly
you struggle
very
from something.
difficult.
Absolutely. And I wasn't struggling mentally. I was just so depleted from lack of sleep. But I totally appreciated that this is the immediate problem. And I think off the top of my head, I think we're not allowed to mention two ailments or two concerns on the same appointment kind of thing. So it's the direct.
So again,
complaint.
Every GP is very different. I was trained in a very pressurized system where we were struggling both for time and for staffing. So I'm quite boundaried with my patients. So I am very much a case of we must try and stick to one problem where we can. I'm also a very thorough person. So everything I do, I want to do it 110%. I want to do it properly and thoroughly and try and get as much sorted as we can in that time that we have. So if a patient comes to me with 2, 3, 4 problems, I can't practice how I want to practice because I can't look into each of those problems thoroughly enough. So most patients are very understanding when I do say, I'm sorry, I can only safely look at one problem today, but I will always spin it back to the patient. I will say, what are all your problems? And they will list, and some of them come in with lists.
Oh, bless them.
Which I actually don't mind, because it means they've come prepared, they know what they want to say. And I will go through that list with them, and I will say, if some of them I think will be quick, then I will deal with that as quickly as I can. But most things aren't quick. And I will ask, okay, which one is bothering you the most today? And then we will start with that. And then I will, some problems actually don't need to see a GP. There are a lot more
pharmacists.
Exactly. There's pharmacists, there's very experienced physios now, you know, and they can also see these other healthcare professionals. So actually some problems can be looked at by other people. So this listing just helps. But one problem I much prefer trying to deal with, but doing it properly and thoroughly.
Because drilling down in one problem for 10 minutes is hard enough.
Exactly.
Right?
Even the simplest of problems.
So we touched on chronic diseases. What about age? Surely tailoring exercise medicine for someone like me, I'm 47, is different than someone who's 70?
Again, it's very personalised. So I must say, I see some 65-year-olds who are actually fitter than maybe some 25-year-olds.
What would you consider in that case? Like if they have bone issues or skeletal problems, when you prescribe exercise as medicine?
Yes, I think it depends on what I'm treating or trying to prevent. So generally, as we get older, there are other sort of issues that come to light that we want to try and treat. So we come up with the term frailty. I don't know whether you've heard of the term frailty, just general frailty. So so frailty is it's a sort of condition where your body and your mind finds it much harder to cope with changes.
Okay, any kind of changes.
Any kind of change. Could be a change in your environment, could be a change to your health, could be a change to what you're eating, what you're drinking, to temperature. It could even be a change to, for example, a change in position. So if, for example, you're going from sitting to standing, as we get older and more frail, our ability to cope with that change in position goes down.
Yes.
Which then leads to other problems like falls, for example, sometimes feeling dizzy when we stand up. These happen the more frail we get. And in general, our frailty goes up as we get older. So for an older person, I might consider exercises to try and help with that.
What type of exercises are this?
So the World Health Organization has set guidelines for all ages on what kind of, how much exercise we should be doing, what type of exercise we should be doing during an average week. So those over 65 years old ideally need to be doing about 150 minutes per week of moderate exercise.
Okay.
Or
split, obviously.
Ideally split, not all in one go. You get more benefits if you split it, but obviously doing it all in one go is better than doing it not at all.
Of course.
So it's all about what you as an individual prefer and what you can fit into your week. And all 75 minutes of vigorous exercise a week. And we can go into what that means later on, maybe.
Yes.
In addition to that, for those aged 65 years old, the World Health Organization also recommend 3 times a week, focusing on strength and balance and coordination.
When you say strength, like lifting weight, for example?
It might not even be lifting weights.
Okay.
Obviously, lifting weights is great. But again, this is quite a common misconception about exercise. When we think of exercise, we think, oh, we must go to the gym, lift some weights, go for a run. Bodybuilding, you name it. It's not just that. Even so much as doing air squats or from sitting to stand and back down again, particularly for a more elderly, more frail person, this might be the extent of it. And that's great. Okay. That is still a strengthening exercise. You're still engaging your muscles. And then as you practice that, and obviously your muscles get used to it, they get stronger, you can then start adding in weights. But this doesn't mean going to the gym. This could just be adding in cans of beans into your hand or a water bottle, or putting a rucksack on your back so you've got a little bit more weight. And so it makes your muscles work a little bit harder. So it doesn't necessarily have to be going to the gym, but certainly strengthening exercises, particularly if you think about your day-to-day life, what movements you go through in that day-to-day life. That could be, as I just mentioned, standing up from the sitting position, walking, climbing up the stairs, carrying your shopping, all of these things. Being active, you can emulate this with exercises at home. The other thing that a lot of people are now focusing on is longevity. Obviously, we want to live as long as we can.
We do.
But we also...
I'm an old mum. I want to be able to rock my grandchildren.
You want to be able to pick your grandchildren up, or even your children. You want to be able to run with them, play football with them. you want to live as long as possible, but not only that, you also want that time to be quality time.
Exactly.
So it's not just about quantity of life. Again, I feel a very common misconception with exercise is I just want to look good. I want to look skinny or fit or toned. Of course.
That too, Nicole.
Of course. But I think the focus needs to shift towards actually longevity and quality of life. And exercise is key for that.
Yes.
And it starts in early life. It starts when we start walking and running, when we're able to do that and we start building our cardiovascular fitness, we start building our strength. The more you can build in your late teens, 20s, 30s, the more you can maintain as during your 30s, 40s, 50s. And then if you can start focusing your activity towards balance, coordination, strength into your 60s, late 60s, 70s, you improve your overall fitness, your overall function. You reduce that frailty that we mentioned. So your ability to cope with changes, any changes at all, improves. And therefore you end up with a better quality of life and also quantity of life as well. So I think that's where the shift needs to happen. And it's not just about looking good.
To think of health.
Being big, being toned, it's about, it's not just about that. Although that's nice to have, it's focusing that shift more on what we've just mentioned.
Because when we're young, we can't really feel the implications of losing that precious health. We can see it maybe in our parents and grandparents, but not necessarily. It's not a direct impact. What are some of the least known, even surprising ways my body can be affected by exercise?
I love this question because it's huge and it's far-reaching.
Wow.
So I think the first thing I want to focus on is maybe the effects on the brain and the mind. Exercise actually increases neurotransmitters in the brain. So neurotransmitters are little tiny chemicals that transfer energy signals from one neuron or one nerve in the brain to another one. So that's how information in the brain travels. And that's how our brain works.
And more movement is a good thing.
There's more connections, more neurotransmitters to do those connections. More activity is better. All right. So it's more to do with sort of higher focus and better memory and things like that. Actually, in dementia, we find that the activity reduces. And actually in ADHD as well, it's due to an inactivity within the brain that actually causes ADHD. So there are conditions where the activity levels in the brain are much lower. So having higher levels of synapses, higher levels of neurotransmitters can be very beneficial. So if we take some examples, there's a neurotransmitter called serotonin.
Yes.
I'm sure whether you've heard of serotonin.
A lovely hormone that we feel after workout or having chocolate.
So that's also comes with dopamine as well, which we can talk about a bit later. But serotonin, it is commonly known as a happy hormone. Now, it's not a hormone in theory, but that's what a lot of
that's what you hear.
That's what you hear about it. Yeah. So, but serotonin has got a lot to do with our mood. So it regulates our mood quite a lot, and it helps us feel happy. So it also helps with our sleep as well, and it helps with our learning and our memory. So having serotonin in the brain is very beneficial to our overall well-being. Interestingly, we give medications, antidepressants. You might have heard of sertraline, citalopram, paroxetine, fluoxetine. So these are all antidepressants. So we give these to people who are struggling a lot with their mental health, with low mood, lack of energy, lack of motivation.
Do you think GPs first explore exercise as medicine before they prescribe Prozac?
No.
It's not a protocol.
It's not a focus in the protocol. So our guidance, we as any doctor in the UK, I'd hope, would follow the NICE guidance, which is our National Institute of Clinical Excellence. Okay. And these are guidance, they're mainly aimed at sort of primary care, but it's guidance for lots of common conditions, and it sets out what sort of treatment plans we should be following and advising to our patients. In most of the NICE guidance, all it says is encourage weight loss, encourage increased activity. And that's all it says. That's all it says. It doesn't give any specifics. It doesn't say offer an exercise prescription. In most of the conditions, it just says consider activity levels.
Healthy lifestyle.
Yeah, consider lifestyle changes. So there's no specifics there. And I think that's where the problem is. And you mix that with a lack of time and a one-size-fits-all approach. And that's when you end up with a lot of healthcare professionals just, oh, here's a medication, try this.
I was really surprised at how quickly I was prescribed that antihistamine. I took it once, and the following day I felt that there's no connection between my tongue and my brain. And even later in the morning, 11 o'clock, 11:30, I felt that stuttering a little bit. And I was 100%. It was antihistamine.
Yeah.
Because I wasn't like that when I was sleep deprived. Yeah. Not that it made a huge difference with my sleep anyway. Yeah, so I stopped it. I thought, no, I'm not going to do that, and just work on other areas of life, try to sort this out anyhow. But yeah, I totally get how it's easier and quicker to go for the pharma. But yet again, this will cost the NHS way more funds when diseases and conditions get worse with secondary care when we get to the consultants and not the primary care.
Yeah. Unfortunately, a lot of people, and it's no one's at fault for it. It's our natural. It's how the system. It's our natural. It's how our brain works. We want the quickest and the most efficient and effective route. That's just the way our brain is, and both patients and actually some healthcare professionals, obviously medications is seen as quite a quick and easy route because it's just something scientific, right? And everything gets better.
So how do you deal with patients when they come to you and they want the pill and not the lifestyle change? What do you say to them?
Good question. At the end of the day, you can't force anyone to do anything. As a doctor, all you can do is give patients as much information as you know, and then it's up to the patients to make an informed decision about what treatment they want. So I always make sure that the patient understands their condition. What are we treating, or what are we trying to prevent? I then go into, I just explore their ideas on what medication do you want? Have you seen something on the internet? Have you heard of a friend who's tried this medication and has magically just gotten better without any problems? I look into why they just want the medication, and I can then use that or explore that to then make sure they're fully informed of other options, of which a lot of the time exercise and activity is one of them. I then explore with the patient where I can. What are their ideas about the exercise? Are there barriers? Are there preconceived ideas about exercise that they don't, that means that they don't want it? So it's all about sitting with the patient really and just really exploring we always say ideas, concerns and expectations. We call it ICE, and it's the core to a lot of consultations that GPs do. We get taught it in our GP training. We get marked on it in all our exams. So it's the patient's ideas, concerns and expectations. And if there's any issue or discrepancy between what you're suggesting and what the patient wants, it's always worth exploring those ideas and concerns and expectations in a lot more detail. And you might actually get to the bottom of why the patient really wants that thing. And there actually might be some misconceptions there or some misunderstandings there that you can address. Or actually there might be some issues there that the patient raises, which me as a clinician hasn't thought about. And that will help just push us towards a bit of a shared decision about what the patient is going to do next.